It is indeed a pleasure and my honor to introduce Dr. Stephen Markowitz. I would say he is from the top shelf. And as we know from wine, the top shelf wine is the best because they're the longest. Dr. Stephen Markowitz, welcome to the Dr. Deborah Brathwaite Annual Symposium. He is an occupational and environmental physician and an epidemiologist. He is also a professor and director of the Barry Commoner Center for Health and the Environment, which is located in the building of Queen's College in Flushing. He also directs the largest occupational lung cancer center screening program in the United States. Without any further ado, I present to you Dr. Stephen Markowitz, who will enlighten you on lung cancer. Thank you. Steve, welcome.
Sure. Thank you. Thank you, Ed. Can you hear me okay? Yeah. So first of all, let me just thank the host organizations for inviting me today to speak. I want to acknowledge Ed Allen, with whom I have worked for the past 15 years at Queen's College, who's helped us work on this program that I'm going to describe today. I have to say that the title of my talk, which identifies diagnosis and treatment, I'm really going to focus on prevention, and in particular on screening, because I think that's the area in which we've made a huge amount of progress that people aren't entirely aware of. So I'm going to focus on that today. I should add that it is a beautiful day here in Brooklyn, and I hope it is a beautiful day wherever you are. Okay, can you see my screen? Okay. Yeah, yes, okay, thank you. So, normally when I give this talk, it's in person, and I ask how many people know somebody who has had lung cancer. And it's usually, at least half the people raise their hands. And then I ask how many people know somebody who has died from lung cancer. And then it's actually usually more than 50%, because lung cancer is that common, and in particular lung cancer till now has really been a very, very tough disease. It remains a tough disease. There is an opening, a window we have to lessen the impact of lung cancer, which I'll be emphasizing. We're going to need to change our thinking about lung cancer in order to get people screened, because we have a perfectly good screening tool to diagnose lung cancer early. I'm going to show you the facts around that. But we can't get people to screening unless they begin to believe that lung cancer is not necessarily a death sentence, that we can diagnose it early and a person can be cured of lung cancer. So we're going to have to get over that common thinking. Lung cancer is due to smoking, absolutely true. Actually, in preparing this, I looked at the smoking rates in the Caribbean, and I was surprised and thrilled to find that the smoking rates are, I'm not going to show you them, but they're very low. I mean, in the US, overall, you got about 25% of adults still smoke. But I'm looking actually at the screen now. You can't see it, but Barbados, 8.7% of adults smoke. Dominican Republic, 9.4%. In Haiti, it's lower. Bahamas, Jamaica, it's 11%. So those islands have done a fantastic job in keeping people from the #1 cause of lung cancer. But I'm going to talk about other causes of lung cancer because there are other causes that are important. The thing is number 3, which is that people with lung cancer that they're at fault for their lung cancer because they smoked. And I think most people who develop lung cancer smoked. They may have had other risk factors, I'll talk about them, but they believe that, some of them believe that they deserve it. They believe that it's their fault. Their healthcare providers, whether they verbalize it or not, believe that it's their fault because they smoked. And I think it's important to understand that smoking is an addiction. Most people get into it when they're teenagers, when their brains aren't entirely formed, right? And they're making some poor judgments. And then by the time their brains come around, they're addicted. Now, a third of people who smoke do manage to quit smoking. So it's not a fatal addiction necessarily, but it is an addiction. And we need to think of compassionately about people with lung cancer, that if they smoked, they don't deserve it. It wasn't their fault, and they deserve appropriate treatment. So I want to talk about two stories, two contrasting people. So what I do sometimes is I testify in court on cases of occupational lung cancer. And so to do that, and I do it in New York and some other places, I tell the story of what happened to the person. And I've had a couple of recent, I don't generally see the people, I review medical records, I know a lot about asbestos, and I talk about how asbestos contributed to this person's lung cancer. So I want to talk about two recent stories or cases. One is a man from Western New York, upstate, 70, fairly healthy, only had hypertension and depression. He had no family history of lung cancer. Family history of lung cancer is a risk factor, okay? It's not as strong as smoking, but it is a risk factor. He had no personal history of any cancer, and he had no history of chronic lung disease. I mention that because chronic lung disease is a risk factor for lung cancer. He was, however, a career insulator. So he spent decades applying asbestos insulation. The application stopped in about 1980 or so, but the lung cancer risk from asbestos doesn't appear for decades, and that's why he developed lung cancer in 2020. So he had plenty of exposure to asbestos, and he was also a heavy smoker. He had two risk factors for lung cancer. So early 2020, he develops for several weeks severe low back pain. This wasn't the kind of low back pain you might live with for a while. He went to see his physician, and they did a CT scan, and right away they saw a destructive lesion in his lower back. And that destructive lesion is essentially cancer until proven otherwise. They also did a CT scan of the chest, and they saw that he had a small mass in his chest and some other nodules as well in his right lung. So they were thinking he probably has cancer, and in fact, if he has, it's metastasized, it's advanced cancer. His chest CT scan also showed a telltale sign of asbestos. Not everybody exposed to asbestos gets this sign, but he had it, which is that in the pleura, the lining of the lung, it had collected calcium, it was thickened, and the radiologist looked at it and said, this looks like asbestos-related disease. So there was a clear signal. They used a CT scan to guide a biopsy of that lesion in the spinal column. They pulled out some tissue and they identified squamous cell carcinoma, and in combination with a PET scan, which showed that there was active cancer in the lung, lymph nodes, and lower spine, they diagnosed metastatic lung cancer. So he had stage 4 lung cancer. It had spread beyond the lung. And importantly, and I'll get into this a little bit later, there were no genetic markers of the cancer tissue to guide treatment. That is, if you know anybody who develops lung cancer, the first question is, was that tissue sent off to the lab for genetic markers so that precision medicine, targeted therapy, or what have you, specific chemotherapy, immunotherapy can be given to that person because they do much better. He had none of those. And so this he continued to get sick. He got sicker and sicker. They gave him opioids for pain. They threw immunotherapy, chemotherapy at him. This was stage 4 lung cancer, so he was likely not to do well. He lost a tremendous amount of weight, continued to suffer back pain. And so they, after a couple of months, stopped chemotherapy because he was actually too weak to sustain it. He entered hospice and died in October 2020, 7 months after diagnosis, typical for stage 4 advanced lung cancer. Now, I want to contrast what happened to him with the second person of the case that I looked at. Also Western New York, a 74-year-old man, had a number of history of health problems that we're all familiar with. He did have a family history of lung cancer, so he had a risk factor there for lung cancer. And he had worked at a Union Carbide plant for 2 years after high school. When you work after high school at a place like that, you always get the dirtiest job. His job was to sweep up asbestos insulation debris. And then for about 15 years, he also replaced brakes and clutches. And in that era, that would have contained asbestos as well. And he smoked, although he quit smoking in 1984. So he quit smoking almost 35 years before he developed lung cancer. You still have some residual lung cancer risk even 30 years after quitting, but it's a lot less than if you hadn't quit. So he had multiple risk factors. And so his healthcare provider did a surveillance chest CT scan in July 2019, and they saw a small mass, a 1-inch mass in the right chest, an enlarged lymph node. They did a PET scan, it lit up that mass, and it was suspicious for malignancy. And so he had chest surgery. And the kind of chest surgery he had is they put a scope. They did not open up the chest. They put a scope through 3 small slits in the chest where they removed one lobe, one of 3 lobes of the right lung, and removed the cancer. Looked under the microscope, it was an adenocarcinoma. He had no spread of cancer. He had no involvement of lymph nodes, and they had removed the entire cancer through this less invasive surgery. His stage was 1B, successfully removed, needed no chemotherapy, has had close medical follow-up, and as of 2 years later, no recurrence of the lung cancer. So there's a tremendous contrast here, right? One man who presented with advanced lung cancer, in which he survived for 7 months, nothing helped him, and another man who clearly had a risk of lung cancer, who had early on a surveillance or screening, a CT scan of the chest, and diagnosed early, and with surgical removal, and is doing fine. And that's the difference between stage 1 and stage 4 lung cancer. Stage 1 is a small lesion confined to the chest, which can be surgically removed. So lung cancer survival, these cases show that lung cancer survival is good when it's diagnosed early. And if you look at this bar graph here, you can see where it's localized, 57% survive, at least survive 5 years. But when it's at diagnosis, if it's distant or advanced or metastatic disease, 7% survive 5 years. So we get good survival, not great, but good survival if it's diagnosed early, and poor survival if it's diagnosed late. So the problem is that most people are diagnosed late. And this shows you, actually this is broken down by race. We'll discuss race a little bit later, but this is the stage at diagnosis. So most people, about 50%, are diagnosed when it's advanced disease, distant disease, and only a quarter or less are diagnosed when it's early stage disease. So that's our problem right there. Survival's good if it's diagnosed early. It's bad if it's diagnosed late, and for most people, it's diagnosed late. And you say this is intuitive. We already knew this. Well, this has clearly been demonstrated through screening studies, which I'll talk about a little bit. So lung cancer deaths, #1 cause of cancer death in the US. Prostate cancer is breast cancer. They're more common, but in terms of dying from cancer, lung cancer is #1. And it's #1 in both women and in men. And you can see here I break it down by gender, and it's about 22% actually in both men and in women. And if you look closely, you'll see in women, lung cancer deaths are more common or as common as the next two causes combined, breast and colon, right? Similarly with men, lung cancer deaths, the percentage exceeds that of the two next most common causes of cancer death, prostate and colon. So clearly lung cancer, it remains extremely important as a cause of death. And I show you here some data by race. Black Americans do worse in terms of lung cancer diagnosis, treatment than white Americans. And you can see these differences don't seem huge. For instance, early diagnosis, 25% of whites diagnosed early, 21% of blacks, but that's a 4% difference. That's roughly 20-25% difference. Similarly, surgical treatment, maybe in part because it's diagnosed later among blacks, surgical treatment's undertaken. Surgical treatment is going for cure. That occurs less frequently among blacks. And also in general, and this is true for many kinds of cancer, that blacks get less treatment, less adequate treatment, and it's true for lung cancer. So let's talk about prevention. And by prevention, we're talking about keeping people from exposures, but I'm going to emphasize secondary prevention, which is detecting disease early. Because if you were exposed to these things, the occupational agents, cigarette smoking, 10 years, 20, 30 years ago, you're at risk. And so what we can do for you now is to screen you for lung cancer. But aside from cigarette smoking, there are occupational exposures. That's what Ed and I spend our time focusing on. General environmental exposures, something called radon, air pollution, and these other risk factors, which I mentioned earlier in those two cases. COPD, emphysema, is a risk factor for lung cancer. So these are the occupational carcinogens. These are the ones we know cause lung cancer. I want to point out a few: diesel exhaust in the left-hand column, still fairly common. Outdoor air pollution, common obviously in cities. Painting is an occupation. Painters are known to have an increased risk of lung cancer. Asbestos we don't use anymore, but there's still plenty of asbestos around, and the like. And then these are some examples. I'm not going to dwell on this for the sake of time, but some examples of the kind of workers who have these exposures to lung carcinogens. But the thing is that most, I'm sure this is your experience, your provider doesn't ask what you do. And if you're retired, that's what you do. That's what's listed on your occupation. You're retired. It's as if you hadn't spent 30 or 40 years working and possibly having exposures. We have to change that. So what we can do now is to screen with an annual low-dose CT scan. And this is the heart of my message here. This is what I'm hoping to get across. A simple chest CT scan using a low dose of radiation, a non-worrisome dose of radiation, gets a very good look at the chest. And this is this picture here is a slice. The CT scan gives you slices across the chest. So for instance, we're looking in the middle at the heart. We're looking at either side, the blackened areas are the lungs. You see it in the back here is the vertebral column. And so this is a slice sort of in the middle of the chest. And what's notable here is this lesion here on the left side. That is a lung cancer. It's one of the cases from our program. It's a small lung cancer. It's isolated. Lymph nodes are not involved. It was removed surgically with a scope, and the person did fine. This kind of CT scan takes 30 seconds. There's no injection. It's low dose. It takes you longer to get your shirt off than it does to actually have the scan. And this is what's now available, and this is the way we can detect lung cancer, and early when it can be treated. And we know this because we've been doing this actually for 20 years now. As soon as the first study came out, 1999, showing that CT scans could do this, we are already responsible for screening people who had built our nuclear bombs around the country. We knew they had exposures to all kinds of exposures that we were worried about: asbestos, radiation, beryllium, and the like. So we introduced lung cancer screening. This is where we ran our program, and in various states across the country. This is where Department of Energy facilities are. It's just an example of one of the places. This building here, 40 acres, very large uranium enrichment plant, where many of our workers worked at. And so in the year 2000, the federal government recognized that these nuclear weapons workers were getting cancer, were dying from their exposures. And so they funded us and they funded others to screen them. And this is 2000 when we started doing this. I'm on the left there. That's how long ago we've been doing this. But there's some other notable politicians, and we couldn't get it from a radiology facility in 2000, so we had to lease our own CT scanner. We put it on a mobile unit, we drove it around, and we scanned these workers from these facilities for lung cancer. And whereas there was a study going that was started at about the same time in Baltimore and New York, in Boston, in the major metropolitan areas, at the tertiary care medical centers. We were out there in Portsmouth, Ohio, and Paducah, Kentucky, with our scanner, essentially providing the same service and demonstrating. And this is our current scanner in Oak Ridge, Tennessee. We park it at the Union Hall because that means that the people we serve feel they own this program. It's their program. And we have excellent compliance because they feel like it's their program. Now, in those days, yes, we had to have our own scanner and circulate it, but I show you here, 2022, in New York City, there are at least 60 centers where you can have low-dose CT scan. Central Brooklyn, we're on Eastern Parkway, Utica. There's a private radiology facility downstate. There's one at Kings County, downtown Brooklyn, out here in Flushing, Queens, and certainly in Manhattan, out here in Bay Ridge and the like. All these centers do exactly this: low dose CT annual to detect lung cancer. So nationally, there are over 4,300 places where people can, in the US, where people can have this done. So this is now a common available procedure. I'm going to skip ahead a little bit because shortage on time here. We've been doing this. We've offered this to these workers who were age 50 and over and who smoked at least 20 pack years. A pack a day for a year is 1 pack year. And we've screened 14,000 workers. We've done a lot of scanning, and we've had excellent participation. 70% of the people we approached enrolled, and if they enrolled, 90% showed up for their scan. So we're doing very well in that respect. And these are some of our results here, and this is actually the key here. We've detected almost 200 lung cancers in the last 20 years. We've screened a lot of people, but we've picked up a lot of lung cancers. And here's the bottom line, which is of those 200 lung cancers, 72%, that's where the circle is, 72% are early stage 1 or stage 2. That's when you can have surgery. That's when you can be cured of lung cancer. And not in Manhattan or in Boston or in Detroit or in Chicago, but in rural areas of the US with community hospitals, we've demonstrated that you can have low-dose CT, and 3/4 of the time, we will detect your lung cancer at an early stage where it can be removed surgically and you should have a normal lifespan. And if we can do it anywhere, then this can be done anywhere. So, and this is a slide I showed before. Remember I said before, most people, majority are diagnosed late stage and not at early stage. We've reversed that entirely. 72% are at early stage. And this has been demonstrated in multiple studies. So now, as part of the Affordable Care Act, the US requires private and public insurance to cover low-dose CT for lung cancer screening. And these are the criteria. You need to know these. If you know anybody age 50 to 80, they smoked at least 20 pack years, so a pack a day for at least 20 years, or 2 packs a day for 10 years, and they quit less than 15 years ago, they can get free low-dose CT scan pretty much anywhere at this point. Personally, I'd like to see a much broader set of criteria, but these are the reimbursed criteria at this point. And actually, the government changed the policy just last year, increasing eligibility. And the net effect of that were that more Blacks and more women became eligible for low-dose CT. They realized that actually at lower levels of smoking, Black Americans had comparable or increased risk of lung cancer compared to whites. So they changed the eligibility criteria. And it's available everywhere. 40, as I said before, 4,300 centers across the US. So that's not the obstacle. I'm an occupational medicine person. I'm very unhappy. No one's talking about the occupational risks, which for many workers, very important. I list some of the carcinogens here. I showed them earlier. They just talk about age and smoking. That's the only criteria they use. Remember I said COPD causes lung cancer, family history of lung cancer is a risk factor. None of that in the government policy at this point is applicable. I would recommend that those factors be weighed in, but and the bad news is that only 14% of people eligible for lung cancer undergo screening. This is, so understand, colonoscopy, we have about 70%. Mammography, it's about 65%. So people go for cancer screening, but right now they're not going for screening for the #1 cause of cancer death in the US. And that's something that we need to change. 12 million people this year will be eligible in the US for this, and they will not undergo low-dose CT. And the reason they don't is because they don't know about it. We need to inform people about this. And some people are either fatalistic or afraid because, as I said before, lung cancer, they consider to be a death sentence. And so they won't go. But somehow we have to overcome that stigma and get people to show up for a very simple test that can reliably save their lives. And so these are favorable factors for screening, but as I said, we need to increase education. We need to address issues of motivation. So let me just spend a couple minutes on diagnosis and treatment. There have been significant advances in diagnosing lung cancer. Doctors, particularly radiologists and lung doctors, can increasingly get at masses through less invasive means, through needling, CT-guided needle biopsy, or putting a scope into your esophagus and inserting a needle that way, so that they can get a diagnosis before they open the chest. And this is increasingly available. This is excellent news because it means less pain for people, less disruption of their lives in order to get a diagnosis. On treatment, there's been some significant advances in treatment. As I mentioned before, if someone's diagnosed with lung cancer, their cancer tissue should be sent off to the right labs to look for genetic markers. If they have one of these genetic mutations, then their treatment should be guided by those mutations. And if not, then they would get treatment anyway, but the more specific, the better. Immunotherapy has appeared in the last 10 years, which has been reasonably effective at treating lung cancer. The oncologists are trying all kinds of combinations of chemotherapy before surgery, immunotherapy in combination with chemotherapy, new kinds of radiation therapy. For older people or sicker people who can't undergo surgery, the radiation oncologists have really fine-tuned this cyber knife type of treatment where they very pinpoint a destruction of cancer tissue that's gotten better and better. So there have been advances. Now, so there are some people with stage 3, stage 4 with advanced lung cancer who can live several years. Long-term survival, not so much, but they can live up to several years because of this improvement in therapy. So I don't want to overstate, we're not getting that many cures from chemotherapy, immunotherapy, or surgery for late-stage disease, but it's not a hopeless situation. And so there are many people who have worked with me and us on this project, and I want to thank you for your attention.
All right, thank you so much, Dr. Markowitz. You can hear me, right?
Yeah.
Okay. So we have a question and answer period a little bit later down, but just want to rank a little bit here and say, does anybody have an immediate question? Does anyone have an immediate question that you can put in the chat, or would you want to ask it right now? If so, you can raise your hand. Okay, so no one has a question? Oh, okay. Oh, yes. What is the relationship between direct smoking and secondhand smoking? Great question. What is the difference? What is the relationship between direct smoking and secondhand smoking? Dr. Markowitz, do you have?
Okay, yeah, thanks. I had to unmute. Yeah. So, yeah, direct smoking is, the person's actively smoking, and they have the highest risk, obviously. For a person who does not smoke, but is exposed to secondhand smoke or environmental tobacco smoke, they have an increased risk of lung cancer if they have, some ongoing exposure. It's not a huge increase in risk. It's 10%, roughly 10% increase in risk, whereas the increased risk for the active smoker is ranging from 500% to 1,000%. So secondhand smoking does constitute a risk. Thank goodness we've restricted smoking so that people aren't unintentionally exposed to cigarette smoke. Many of you probably remember when you'd be hard pressed to go to a restaurant without being, or be in an airplane without being subjected to smoke. So they both constitute lung cancer risk. Active smoking far, far greater than passive or secondhand smoke or environmental tobacco smoke. I hope that's the answer to the question.
Okay, thank you so much. Yeah, because I was gonna kind of go in that direction myself because my brother was not really a smoker. Yes, as a younger person, because he was young, he was relatively young, he was like 36.
Wow.
And
Wow.
it was a rare form. It started out as a DVT in his leg, and ultimately having too many of those at an early age and blood thinners wasn't helping. They kind of started looking deeper and found that it was more than that. Someone said, would treatment be the same?
Oh yeah, I mean the treatment's the same regardless of the cause. So whether the lung cancer is, that's why healthcare providers don't focus on cause, because the treatment's the same. So if you smoke, they'll say, okay, it's caused by smoking. They won't look at anything else. But yeah, the clinical disease is the same, whether it's caused by COPD, smoking, asbestos, you name it.
Okay, treatment's the same. All right, thank you.